doctors and all the candidates for the Mrcp basis. I have come with yet another case for the Mrcp basis abdominal stations, and today I'm going to talk a bit about the liver transplant. This is very common case in abdominal station and it appears frequently. Okay, let's move on. This is our case scenario. So you're presented with a 52-year-old male, Mr. Khan, who is here for a routine follow-up visit. Please perform the abdomen and relevant examination. Okay, so as this is an abdominal station, so we no need to take any history from the patient. Once you enter the station, introduce yourself, get the consent, and start with the examination. We're going to do the general inspection first. So look for any jaundice, any pallor, or any signs of chronic liver disease like spider nevi or palmar erythema. Then we're going to check the vital signs, or we can ask the vital signs from the examiner. We want to know about the blood pressure, heart rate, and temperature for any signs of infection or hemodynamic instability. On the abdominal examination, inspect for the surgical scars indicating previous transplant surgery. And then after that, we're going to palpate for any hepatomegaly, any splenomegaly, or any tenderness. And we also want to make sure that we don't miss any SITs. This is quite straightforward actually station. And once you do the inspection, you can see this scar which is on the right hypochondrium, and sometimes the scar is going up also, something like this, and sometimes it may extend to the left hypochondrium as well, and this is normally known as the Mercedes-Benz scar. So once you see this scar, then it is obvious that the diagnosis is a liver transplant. So after that, you will be thinking about all the causes of the liver transplant. And whenever, in any case of the transplant, there are only 3 questions to answer. First of all, that you know this is a liver transplant. Second, what are the causes of the liver transplant? If you can find any, maybe because of the chronic liver disease or any other causes. We'll discuss the causes later. And the third thing, is the transplant working, or are there any complications related to the transplant? Here you can see maybe once you do the examination of the skin, so look for any new lesions or signs of skin cancer, which can be more common post-transplant, which are more common due to immunosuppression. So here we can see some palmar erythema here, and this is spider nevi. So look for these whenever you come across the liver transplant case. And after that, in the systemic examination, check for any lymphadenopathy, so which could suggest infection or malignancy. Abdominal examination, I'm sure you all are aware. So just be systematic and start with the inspection and then palpation and percussion. So I think you are all aware about this one. I briefly put some causes of the liver transplant because this is a very common question an examiner will ask in this station. So it's always better to divide it into different groups. So we have chronic liver diseases or cirrhosis, which are the causes of the liver transplant, like hepatitis C. So prior to the advent of effective antiviral therapy, it was the leading cause for liver transplant. However, this has been changed with the introduction of a more effective antiviral drugs. Another cause of chronic cause for the liver transplant is alcoholic liver disease. So chronic alcohol abuse leading to cirrhosis is a common indication for transplant, and the patients are often required to demonstrate abstinence and engaged in addiction treatment program before they are considered for the transplant. Non-alcoholic steatohepatitis, part of the spectrum of non-alcoholic fatty liver disease, is a leading cause of liver transplant due to rising prevalence of obesity and metabolic syndrome. Hepatitis B, the rate of transplantation has decreased because of the effective antiviral therapies. However, it is still there. Autoimmune hepatitis, the body immune system attacks the liver cells, so it can lead to inflammation and progressively, potentially progressing to cirrhosis, so another cause of liver transplant. Primary biliary cholangitis and primary sclerosing cholangitis. So these affects the liver bile ducts and leading to cirrhosis and liver failure. So these are all the chronic causes: hepatitis C, alcoholic liver disease, non-alcoholic steatohepatitis, hepatitis B, autoimmune hepatitis, and primary biliary cirrhosis. So another group which we should consider in which the liver transplant is considered is acute liver failure, in which there is a rapid loss of liver function in someone without pre-existing liver disease. So it can be because of the drug-induced liver injury, overdose of medications like acetaminophen, like paracetamol, or viral hepatitis. Acute viral hepatitis, we're talking about A, B, and E. Autoimmune hepatitis, injection of certain toxin substance such as mushrooms, amanita phthaloids. And the third group is metabolic liver diseases. They are genetic conditions affecting the liver metabolism, like Wilson's disease. We all know this is a disorder of copper metabolism, and it leads to copper accumulation in the liver, brain, and other organs. Alpha-1 antitrypsin deficiency, and hemochromatosis, which is excessive iron accumulation in the liver. So these are the metabolic liver diseases, and in which sometimes liver transplant could be there. And the liver tumors, hepatocellular carcinoma is the most common type of liver cancer. So can be considered in the early stages, but they are following there is specific criteria for that. And rare liver tumors may also be considered for transplant. Other causes include biliary atresia, in which the bile duct are absent or blocked, leading to liver damage, and it is the most common reason for liver transplant in children. And then we have cystic disease of the liver, polycystic liver disease, and choledochal cyst, which may sometimes require transplantation. So these are the main 5 groups for the which can lead to liver transplant. How about the investigations approach? We want to do the routine monitoring. We want to look for the liver function tests, AST, ALT, alkaline phosphatase, gamma GT, bilirubin, and albumin level. We want to monitor the liver function and detect any early signs of graft rejection or any dysfunction. Renal functions are important, creatinine and electrolytes, to assess the renal function. And because we are aware that all these patients are on immunosuppressive drugs for the transplant, so we are looking for any potential nephrotoxicity. Full blood count to detect signs of infection, anemia, or thrombocytopenia. Immunosuppressive drug levels, so monitoring level of the immunosuppressive drugs like tacrolimus or cyclosporine to ensure therapeutic levels, and we want to minimize the toxicity. Virology and infectious screening, cytomegalovirus and Epstein-Barr virus PCR to detect any cytomegalovirus and Epstein-Barr virus reactivation, which are common post-transplant. Hepatitis B and C viruses, in which case was due to viral hepatitis, monitoring for any viral recurrences. Imaging, Doppler ultrasound of the liver, because we want to assess the blood flow through the hepatic artery, portal vein, and hepatic vein. So to look for any vascular complications. Abdominal ultrasound or CT scan for anatomical assessment and to rule out biliary complications or any fluid collections. Liver biopsy, well, it is considered the gold standard for diagnosing rejection, assessing the degree of liver inflammation or fibrosis if suspected. So this is our investigation approach. Then about the management approach, as I already told, we have to give these patients immunosuppression. So we want to tailor the immunosuppressive regimen to minimize the side effects while preventing rejection. So this typically involves a combination of corticosteroids and calcineural inhibitors like tacrolimus and cyclosporine, and anti-proliferative agents like mycophenolate mofetil. So remember these drugs, because sometimes the examiner may ask about what immunosuppressions you're going to give for these patients. So monitor and adjust dosage based on drug level, kidney function, and side effects profile. Infection prophylaxis and treatment. So prophylactic antimicrobial therapy may be indicated for pneumocystis jirovecii pneumonia, fungal infections, and viral reactivations, for example, cytomegalovirus. And obviously, we want to treat any infections with appropriate antimicrobials, which are guided by the culture and sensitivity. Management of complications. In this, remember the complications include rejection. So acute rejection is usually treated with high-dose corticosteroids and adjustments to baseline immunosuppression. Vascular complications. In the vascular complications, interventional radiology or surgical revision for thrombosis or stenosis, and biliary complications. Again, we need some endoscopic or surgical intervention for strictures or leaks. Long-term monitoring and care, so regular follow-up with a MDT, which includes hepatologist, transplant surgeon, and specialists in infectious diseases, and monitoring for and management of chronic conditions like hypertension, diabetes, and renal dysfunctions. These are all can be exacerbated by immunosuppression. And screening for malignancies, especially skin cancer and post-transplant lymphoproliferative disorder, given the increased risk due to chronic immunosuppressions. Lifestyle and support, so nutritional counseling and support to maintain a healthy weight and manage the metabolic effects of the medication. And psychological support, don't forget this, is very important for patient and families. So addressing the emotional and mental health challenges for the post-transplant. So try to remember as much as you can, always divide into groups. I've already, so talk about the immunosuppression, you talk about infection prophylaxis and treatment, any complications, we want to manage any complications, long-term monitoring and care, and finally lifestyle and support. I have put some of the questions which are commonly asked, is more of a repetitions. What are the common indications for liver transplants? So common indications we have already discussed in detail, which includes chronic liver diseases leading to cirrhosis such as hepatitis C, alcoholic liver disease, non-alcoholic steatohepatitis, autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and metabolic liver diseases like Wilson's disease and alpha-1 antitrypsin deficiency. And don't forget acute liver failures, hepatocellular carcinoma, and within certain criteria and specific genetic metabolic disorders. These are also indications. What are the main complications of post-liver transplant that a physician should monitor for? So post-transplant complications include acute and chronic graft rejections, and then can be infections due to immunosuppressions, bacterial, viral, or fungal, and drug toxicity, particularly nephrotoxicity from calcineural inhibitors. There can be recurrence of the original liver disease, vascular complications, which include hepatic artery thrombosis or portal vein thrombosis. We can have biliary complications like strictures, leaks, or then the development of other diseases because of the immunosuppressions like new onset diabetes, hypertension, or renal impairment. How is acute rejection identified and managed in liver transplantation? So acute rejection is typically suspected based on clinical signs. We like fever, malaise, elevated liver enzymes, and they usually confirm with liver biopsy. It shows some inflammatory infiltrates and damage to bile ducts and blood vessels. So management usually involves high-dose corticosteroids and adjusting the baseline immunosuppressive regimen to more effectively prevent immune-mediated graft damage. The role of immunosuppression in the management of liver transplantation. We all know that immunosuppression, these are critical in preventing graft rejections. The regimen starts with a combination of medications to suppress the immune systems. Remember these groups: calcineurin inhibitors, tacrolimus, cyclosporine, anti-proliferative agents like mycophenolate mofetil, and steroids. And the dose and combinations, these are adjusted based on the patient response, on the drug levels and side effects, and our goal is to minimize the drug toxicity while preventing the rejection. Long-term consideration for patient with liver transplant. So long-term consideration, we are interested in the patient adherence to the immunosuppressive medications, regular monitoring for signs of rejections, any management of any comorbid conditions like hypertension and diabetes, and prevention and early detection of infections, surveillance for malignancies, especially skin cancers and liver transplant, lymphoproliferative disorders, and obviously lifestyle modifications to maintain overall health and liver functions. How is hepatocellular carcinoma managed in context of liver transplant? So patient with hepatocellular carcinoma may be candidate for liver transplant if the tumor meets specific criteria. And here, remember this Milan criteria. One should have a single tumor which is less than 5 centimeter or up to 3 tumors all less than 3 centimeter. And this transplantation offers the chance for cure, removing both the tumor and the cirrhotic liver at the risk of future tumors. And pre-transplant treatments may include some therapies like transarterial chemoembolization or ablation to control the tumor and prevent progression while on the transplant waiting list. So that's all for the presentation. Hopefully I've covered everything about the liver transplant, and it will help you in your preparation for the MRCP basis abdominal station, specifically when you come across the case of the liver transplant. Thank you very much, and I'll see you in my next presentation.